Hello, I'm Michael Rosen. I'm a professor of pediatrics at Stanford University, and I'm a pediatric gastroenterologist. And I direct the Center for IBD and Celiac Disease at Stanford Medicine Children's Health. And I'm happy to be able to talk with you today to answer the question, how can therapeutic drug monitoring be used to optimize inflammatory bowel disease treatment? So here are our learning objectives. By the end of this talk, I'd like you to be able to define proactive and reactive therapeutic drug monitoring, to understand the strengths and limitations of the evidence around proactive therapeutic drug monitoring for inflammatory bowel disease, and to learn to interpret therapeutic drug monitoring results and change management appropriately. Our agenda for this talk will be as follows. We'll discuss features and burden of IBD, IBD treatment goals, the role of biologics for IBD treatment. Then we'll move into biologic pharmacokinetics and immunogenicity. We'll discuss the relationship between drug levels and outcomes. We'll discuss various therapeutic drug monitoring strategies and the assays used. Then we'll move into the evidence around TDM effectiveness. And we'll end by discussing a practical approach to therapeutic drug monitoring and future directions and takeaway points. So let's start with the features and burden of IBD. And we'll start with a discussion of what inflammatory bowel disease is, because this is a general audience of mixed backgrounds and expertise. So inflammatory bowel disease includes Crohn's disease and ulcerative colitis, and these are chronic disorders of intestinal inflammation in which environmental influences trigger a dysregulated immune response to predominantly intestinal microbes in genetically predisposed individuals. The symptoms of inflammatory bowel disease can be quite debilitating and can include abdominal pain, diarrhea, bloody stools, fatigue, and in our younger patients, growth failure. So a little bit about the two primary forms of inflammatory bowel disease. Ulcerative colitis predominantly affects the colon or large bowel and extends from the rectum more proximally in the colon and can maximally involve the entire colon, where we call it pancolitis. Crohn's disease, on the other hand, can affect any part of the intestine from the mouth to the anus and has a more patchy distribution of inflammation as opposed to the more continuous distribution in ulcerative colitis. Most commonly in Crohn's disease, the last part of the small bowel, called the ileum, and the colon are affected. These are pictures of normal colon and those affected by inflammatory bowel disease through an endoscope during colonoscopy. So on the left, you see a normal colon with a delicate thin lining, reflected light from the endoscope, and nice folds. In the middle, you see a colon from a patient with ulcerative colitis where many of these features are lost. You do not see the blood vessels any longer under the surface, and you have this granular, diffuse inflammation. And then on the right, you see a picture from a patient with Crohn's disease, characterized by this deep linear ulceration. But you see adjacent to it fairly normal tissue, highlighting the patchy nature of Crohn's disease. And the other feature of Crohn's disease demonstrated by this picture is how deep and penetrating the inflammation can be, which we call transmural or through the wall in Crohn's disease. And this can result in complications like perforation, abscess in the intra-abdominal abscess, and stricture. The global burden of inflammatory bowel disease continues to rise. Over the last century, the incidence continued to rise in Western countries, and it's now peaked in Western countries. But in developing countries, the incidence of IBD is increasing 5 to 15% per year. And due to the concept of compounding prevalence, that is, new cases outpacing mortality, the prevalence of IBD, the number of cases existing at any given point in time, is expected to rise to over 1% or 1 in 100 individuals in Western countries by 2028. So this is a growing global problem. Let's move on to discuss IBD treatment goals. So one important concept that I discuss with my patients regularly is that symptoms of IBD are really the tip of the iceberg regarding what is going on. And they may be reflective of a much greater extent of intestinal damage and inflammation going on under the surface. So this concept of intestinal damage and preventing it is displayed in the graph on the right. And in patients, inflammation, represented by the undulating black line at the bottom of this graph, can come and go and may or may not rise to the level that it creates symptoms. But as inflammation ebbs and flows, damage to the intestine, represented in this blue line, is accumulating over time. And this damage can be irreversible, and it can result in complications like stricture, poor colon function, fistula abscess. It can lead to needing surgery in patients. And so an important concept in treatment is to pursue tight control and monitoring with the goal of suppressing inflammation, regardless of whether there are symptoms, to prevent that accumulative damage and complications from the disease. And so we in the IBD community have now adopted a treat-to-target approach, where in patients with active IBD, yes, of course, we have a treatment goal of improving symptoms and improving quality of life. But more than that, we want to treat to reduce inflammation or suppress inflammation. And to do that, we treat to other targets, such as biomarkers, including C-reactive protein or CRP, stool calprotectin, a sensitive marker of intestinal inflammation, and then ultimately later targets like endoscopic healing and normalization of growth in children. And this treat-to-target approach has been proven effective for optimizing outcomes. So here I'm sharing a randomized controlled trial called the CALM study, which is a multi-center randomized controlled phase 3 trial of tight control management for Crohn's disease. So in the CALM trial, patients were treated with a prednisone burst, which was tapered, and randomized to either a clinical management group or a tight control group. In a clinical management group, their treatment was escalated with adalimumab, an anti-TNF biologic drug, and azathioprine in a scheduled approach driven by clinical symptoms and prednisone use. Whereas in the tight control group, escalation was driven by symptoms, but also by fecal calprotectin, CRP, and prednisone use. So the tight control group used biomarkers of inflammation in addition to symptoms to drive dose escalation and intensification. And these patients were followed for 48 weeks. The primary endpoint was endoscopic healing with no deep ulcers. And on the graph on the left, you see that the tight control group in light blue had a much higher rate of endoscopic healing and no deep ulcers compared to the clinical management group. In addition, at all time points, steroid-free clinical remission was higher in the tight control group compared to the clinical management group. So the CALM study proved that treating to tight control using biomarkers of inflammation results in superior outcomes in patients with Crohn's disease. So let's move on to the role of biologics for IBD treatments and start with an introduction to biologic drugs. What is a biological product? Well, biologics are large, complex molecules that are made from living sources, such as bacteria, yeast, and animal cells. In the case of treatments for inflammatory bowel disease, these are all therapeutic monoclonal antibodies. And so in this graphic, you see a representative biologic therapeutic monoclonal antibody in comparison to aspirin, which is probably one of the most common small molecule drugs used. And you can see that the high degree of complexity and the much greater size of the biologic product compared to a small molecule like aspirin. Now, I'd also like to briefly introduce you to biosimilar products. A biosimilar is a biologic medicine that is highly similar to and has no clinically meaningful differences from an existing biologic, which we call a reference product. And so typically, as shown on the image on the right, biosimilar products will have the same amino acid sequence and protein structure as the reference product, but their higher order structure and things like post-translational modifications, including glycosylations to the proteins, may be slightly different because they're made in different living systems. And importantly, these changes can even drift over time in the reference product with lot-to-lot variation. So what are the current biologic drugs available for the treatment of inflammatory bowel disease, and how do they work? Well, our first biologics available for IBD were the anti-TNF biologic drugs. And these drugs either neutralize circulating TNF or tumor necrosis factor, or bind to TNF on the surface of effector cells and induce their apoptosis. Then biologics that inhibited lymphocyte trafficking were introduced. And these are the anti-integrin biologics. And the one used most commonly now in clinical practice is vedolizumab, which blocks alpha-4 beta-7 on circulating lymphocytes. This prevents alpha-4 beta-7 integrin from binding MAdCAM on endothelial cells, and therefore it prevents the lymphocytes from egressing out of the blood cells into the intestinal tissues. And lastly, we have additional biologics that block different cytokines, including IL-12 and IL-23. The two ones available currently are ustekinumab, which blocks both IL-12 and IL-23, and risankizumab, which blocks IL-23 alone. Now, while biologic drugs have transformed the care of patients with inflammatory bowel disease, there are some opportunities for improvement. So here, this graphic represents the therapeutic ceiling of IBD therapy, and it shows clinical remission rates for ulcerative colitis across recent clinical trials for biologic drugs and some new small molecules. And so the remission rates in the treatment group are on the left, and in the placebo group are on the right. And on the far right, it shows the delta between these two rates. And what you can see is that once we move past infliksymab, an anti-TNF biologic drug, the first introduced, we've hit this ceiling where the deltas between the treatment group and the placebo group remission rates really haven't exceeded 10 to 12% for any drug. So there's a clear need to optimize the efficacy of our IBD biologic drugs. Another problem with using biologic to treat IBD is durability. How long will the drug continue to work for a patient? This is a graph showing pediatric patients across multiple centers treated with infliksymab for Crohn's disease. Most were treated with standard dosing of infliksymab. And you see that over a 3-year time period, nearly 40% of patients lost response and ended up coming off infliksymab. So we don't just want these medicines to be effective for patients, we want them to be effective for patients for long periods of time. And we need tools to maximize durability of efficacy. So next, let's talk a little bit about pharmacokinetics and immunogenicity of biologic drugs, because this really impacts how we can optimize their use. So because biologic drugs are large, complex molecules, they can induce an immune response in our bodies, and we can develop antibodies to the drug. These antibodies can neutralize the drug binding to the binding site for the drug target. They can form immune complexes and result in infusion reactions, serum sickness, or anaphylaxis. And they can accelerate Fc gamma receptor mediated clearance of the drug through the reticuloendothelial system. And so many studies have demonstrated the association between anti-drug antibodies and accelerated biologic drug clearance. These are two studies that I participated in, correlating anti-TNF antibody level and clearance. And you see this strong association in both studies. And so how do anti-drug antibodies occur, and what are ways we can consider to prevent them? Well, we can take a little lesson from history. And when we first started using infliksymab, the first biologic used for Crohn's disease, which blocks anti-TNF, it was initially used with intermittent dosing. And so these graphs represent a concentration over time curves of the drug in a patient. And so with intermittent dosing, you get a dose of the drug and then it clears out of the system. And then you have long periods without exposure to the drug before another dose is given. And what we found was that this was an excellent way to immunize patients against the drug and created a lot of patients developing antibodies. So fairly quickly, we moved to maintenance dosing of these drugs, realizing that this resulted in a lower rate of antibody formation. And with maintenance dosing, we're assuming that patients are getting a sufficient dose so they have a minimal lowest level of exposure throughout their treatment course. But in reality, there's a lot of variation in patient pharmacokinetics. And many patients would still clear the drug before the next dose, resulting still in gaps in exposure. And so, in effect, this is still like intermittent dosing, and it increases the risk of antibody formation. So, in theory, if we could achieve a minimal drug exposure in all patients, we would do a better job at preventing antibody formation. Well, why is there such variability in anti-TNF clearance? And we wrote a review several years ago on this and presented the concept of the sponge, the shark, and the sieve. So these are mechanisms of anti-TNF clearance that can be variable in patients depending on disease severity. So the sponge represents the high burden of antigen targeted by the biologic, in this case TNF, that sops up immediately the therapeutic monoclonal antibody. The shark represents the reticuloendothelial phagocytes, which take in the therapeutic antibody and degrade it. And this system can be upregulated in the setting of inflammation. And the sieve represents the highly inflamed, leaky guts in patients with severe colitis in particular, where they lose proteins in the blood like albumin. And in addition, they lose the therapeutic monoclonal antibody through the leaky bowel like a sieve. And so depending on patient factors and disease severities, all of these mechanisms can be different in patients and can lead to a lot of variability in drug clearance. We studied this in pediatric patients, and we could use a Bayesian pharmacokinetic modeling to develop models to predict patient drug exposure. And what we found was that when we included factors, including albumin, the antibody levels, and measures of inflammation, like the erythrocyte sedimentation rate, or ESR, we could do a much better job predicting a patient's exposure than when we used weight alone, and that's what's done in clinical practice. And so then using these models, we could simulate exposure for 1,000 patients. And we found that using these simulations, we could only expect about 24% of patients to achieve maintenance trough drug levels of 5 micrograms per ml, which we considered to be a target level, with the standard dosing of 5 mg per kg every 8 weeks. And so what we're learning here is that standard dosing may not be sufficient for all patients. So do levels truly matter for improving outcomes and reducing anti-drug antibodies? What does the evidence show? Well, there are many, many studies associating low drug levels with poor outcomes. But one of the most convincing study is the PANTS cohort study, where they followed over 1,500 adult and pediatric anti-TNF naive patients treated with infliksymab or adalimumab. And at 52 weeks, they found that the likelihood of non-remission was much higher in patients with the lowest drug levels at the end of induction therapy. And that's shown on the graph on the right, which displays quartiles of drug levels on the x-axis and the percent of patients not in remission and non-remission on the y-axis. And you can see that for both infliksymab and adalimumab, that the chance of non-remission was sort of lockstep with lower drug levels at the end of induction. And they found that optimal concentrations associated with remission at the end of 52 weeks were infliksymab levels over 7 micrograms per ml and adalimumab concentrations over 12 micrograms per ml. The PANTS study also nicely demonstrated that low anti-TNF drug levels after induction are associated with later antibody development. So these Kaplan-Meier curves show survival without development of antibody on the y-axis and time since treatment on the x-axis. The red and green are the lowest quartiles of drug levels. And you see that those with the lowest quartiles of drug levels had the highest rate of development of anti-drug antibodies in both the infliksymab and adalimumab treated patients. So low drug levels at the beginning of treatment are strongly associated with the development of anti-drug antibodies. So as I said, there are many studies associating drug concentrations with outcomes. This slide is an attempt to summarize the results of dozens of studies. And so what I've chosen to show here are concentration thresholds associated with either endoscopic or biochemical remission. And these are concentration thresholds for the end of induction or maintenance therapy. And while there's many more studies for infliksymab and adalimumab, there's a particularly limited number of studies for adalimumab in ulcerative colitis and ustekinumab in ulcerative colitis. But one nice way to keep it simple is we can follow this rule of 5s in general for reactive therapeutic drug monitoring in maintenance. And these units are all in micrograms per ml. But what we might be able to keep to memory is a target level of ustekinumab of 5, infliksymab or adalimumab of 10, and vedolizumab of 15. And while this is a simplification of a large number of studies, this is a reasonable rule of thumb to follow. Now, I'd like to come back for a moment to the concept of immunogenicity in anti-drug antibody development and introduce the concept that we can use another drug, namely an immune modulator drug like methotrexate or azathioprine, to reduce the risk of anti-drug antibodies. And so again, this is data from that prospective PANTS study, and it shows that for both infliksymab and adalimumab, when patients used an immune modulator drug in addition to the anti-TNF biologic, it reduced the risk of antibody development significantly. What we've also learned is that one can add an immune modulator drug after the development of anti-drug antibodies and oftentimes be able to reverse those antibodies. So we performed one of the larger cohort studies of this phenomenon. We did a retrospective study of 89 pediatric patients with first development of anti-drug antibodies on infliksymab or adalimumab. And we compared courses and outcomes after the addition of immune modulator drug to those managed without an immune modulator drug. And what we found was that we could reverse anti-drug antibody levels as high as over 2,000 nanograms per ml with the addition of an immune modulator drug. And 87% of those treated with an immune modulator were able to remain on the initial anti-TNF at 12 months compared to only 53% of those not treated with immune modulators. We also found that the drug and anti-drug antibody concentrations predicted the likelihood of ADA reversal without immune modulator. So lower levels were more likely to be reversed just by increasing the dose. And that's shown in this Kaplan-Meier curve on the right, which shows the percent on initial anti-TNF on the y-axis and days from detection of anti-drug antibodies on the x-axis. And you see that those patients with an anti-drug antibody level less than 329 nanograms per ml or a TNF level greater than 2.8 were much likelier to remain on the initial anti-TNF drug with just dose escalation alone, no addition of an immune modulator, compared to those with anti-drug antibody levels greater than 329 and TNF levels less than 2.8, or anti-TNF levels less than 2.8. So one can add an immune modulator after the development of antibodies to reverse those antibodies in select patients. Let's move on to discuss some therapeutic drug monitoring strategies and the assays used. So there are two main strategies for using therapeutic drug monitoring to manage anti-TNF biologic drugs in inflammatory bowel disease. And an important point I want to make is that these two strategies are not mutually exclusive. They can be performed together. So one is reactive TDM, which is measuring drug and anti-drug antibody levels in response to an IBD exacerbation to inform management for achieving disease remission. So in this case, a patient exhibits signs of disease activity, either through symptoms or laboratory abnormalities or endoscopic or radiographic findings. And in response to that, one measures drug and anti-drug antibody levels to determine what steps to take next. Now, proactive therapeutic drug monitoring is when we measure drug and anti-drug antibody levels during initiation or remission with the goal of suppressing inflammation and preventing future disease exacerbation. So in this case, we're measuring drug levels in patients who are improving or who have no disease activity, in the idea that that will help us tailor the drug therapy to maximize its effectiveness and durability. But there are some ambiguities about therapeutic drug monitoring. For reactive TDM, what constitutes an exacerbation? Is it just symptoms? Is it a rise in CRP, in calprotectin? I would argue that this should be performed, of course, in response to symptoms, but also in response to other evidence of disease activity, like CRP and calprotectin elevations when other reasons have been excluded. And what antibody levels are clinically significant? And this is a tough question due to variation in the assays used and the units that are used to measure anti-drug antibody levels. For proactive therapeutic drug monitoring, how often do we do it? Just after induction, with every dose, once a year? And you'll see there's great variability in what's been studied. And then what is our threshold target? Of the dozens of studies, there's an equal number of target thresholds proposed and certainly ranges. And we'll talk a little more about these targets and how we approach them. So this table summarizes some of the characteristics of the assays used for measuring biologic drug and anti-drug antibody concentrations. There are three main types of assays being used today. One is our antibody-based assays, another are functional assays, and then the third class are protein-based assays. So the antibody-based assays include ELISAs and ECLIAs. The first generation ELISA assays were drug sensitive. So this is an important concept, the idea of an assay being drug sensitive or drug tolerant. In a drug sensitive assay, one is unable to detect antibodies in the presence of a drug level. Whereas in a drug tolerant assay, the results are independent of one another, and we're equally able to detect antibodies whether drug is present or not present. And so in the first generation ELISA assays, these were drug sensitive and you were unable to detect antibody in the presence of drug. But newer generation antibodies, and most that are on the market now, are drug tolerant, and you can detect antibodies in the presence of drug. For the functional assays, use a cell-based reporter system. And for this reason, because it really measures the function of the drug and anti-drug antibody, these are drug sensitive in general, and you cannot detect antibody in the setting of a drug level. And then for the protein-based assays were designed to be drug tolerant, and for drug and anti-drug antibody levels, a common one is the homogeneous mobility shift assay, or HMSA. The LC-MS-MS is only used to measure drug levels. Another important point I'd like to make is all these different units used for anti-drug antibodies. And there's a tremendous variation amongst assays in the sensitivity for anti-drug antibodies and how they're reported, which makes them difficult, if not impossible, to compare across assays. And this gets to the important, and I'll mention this a couple of times, of knowing your assay and becoming familiar with the assay that you use in clinical practice. Generally, drug concentrations are reasonably comparable, and they're at least reported in the same units typically, which is nanograms per ml or nanograms per ml equivalents for functional assays. The last concept I'd like to introduce with regards to assays are reflex assays, which are really strategies employed by the lab and in which anti-drug antibody levels are only performed if a drug level is below a specified threshold. And this is a reasonable approach because it assumes that that antibody information is not important if there's a sufficient drug level. So now let's move into the meat of the evidence around proactive TDM and its effectiveness. And I'm going to start by sharing some observational studies and then move into some examples of randomized controlled trials performed for TDM. So some of our first evidence came from this multi-center retrospective cohort study of 276 adult patients with IBD on infliksymab maintenance therapy. And here they compared patients managed with proactive TDM compared to those managed with reactive TDM. And they found improved outcomes in those managed with proactive compared to reactive TDM. So the Kaplan-Meier curve on the left shows the incidence of treatment failure over time, and you see that treatment failure occurred with much greater incidence in the reactive TDM arm compared to the proactive TDM arm. Similar results were seen for IBD-related surgery, as shown on the graph on the right. There were a number of other outcomes looked at that were also significantly different, including hospitalization, anti-drug antibody development, and serious infusion reactions. We performed a retrospective study with historical controls of a practice-wide anti-TNF proactive TDM quality improvement initiative. And this was when I was at Cincinnati Children's Hospital. And so in practice there, we instituted a quality improvement initiative where we gave key recommendations and internal guidelines. And so the crux of these recommendations were to start with monotherapy of anti-TNF drugs, adalimumab and infliksymab, to monitor trough levels proactively after induction, annually and reactively in response to new disease activity, to optimize drug dose and/or frequency to attain a trough level greater than 5 micrograms per ml. And then we provided guidance on the interpretation and response to anti-drug antibodies. And so the primary outcome we looked at was sustained corticosteroid-free remission between 22 and 52 weeks after initiation of treatment. So at all time points in clinical remission between these periods. And we found that there was indeed a higher rate of sustained clinical remission in the group managed after the initiation of this QI initiative compared to those managed before, with a delta of 17.5%. And this held up to multivariable logistic regression to address any confounders or potential differences between the two groups, which were quite similar overall. We also found that there was a reduced incidence of the development of higher titer clinically significant anti-drug antibodies in the patients managed after the TDM guidelines compared to those managed before the TDM guidelines, as shown in this Kaplan-Meier curve. So what this data shows is that we can indeed improve outcomes in a practice-wide approach using therapeutic drug monitoring as part of a quality improvement initiative. All right, now I'd like to give you some examples of randomized controlled trials of therapeutic drug monitoring for IBD. And so the first landmark trial was the TAXIT trial. This was a double-blind randomized controlled trial of infliksymab dosing based on clinical status versus trough concentrations. And so this included patients with both Crohn's disease and ulcerative colitis. They had to be on infliksymab for at least 14 weeks and have had stable clinical response at least, not necessarily clinical remission. And they were randomized to 2 arms. Importantly, both arms had the same initial management, which was an initial dose optimization to an infliksymab concentration between 3 and 7 micrograms per ml. And then after this optimization phase, they were followed for 52 weeks in one of 2 arms, an infliksymab concentration-based dosing versus a clinically based dosing with escalation for symptoms and CRP. And the primary outcome was clinical and biochemical remission at the end of that 52 weeks. So this data is the result of that initial dose optimization period. And what they found is that the percent of patients, at least for Crohn's disease, in remission increased after that initial dose optimization. And the mean CRP also decreased and statistically significantly for the Crohn's disease patients. So a point I'd like to make here is in essence, all patients in this randomized controlled trial received initial therapeutic drug monitoring, proactive therapeutic drug monitoring with dose optimization. Moving to the primary endpoint at the end of the 52-week follow-up period, there was no statistically significant difference in the primary outcome of clinical remission between the clinically based dosing and the concentration-based dosing as shown on the left. Now, this examines a snapshot of clinical remission at 52 weeks, but a secondary outcome was relapse-free survival compared between the two groups. How many patients went the entire 52 weeks without a relapse? And what they found was that relapse-free survival was greater in the concentration-based dosing compared to the clinically based dosing, as shown in this Kaplan-Meier curve, where concentration-based dosing is in red and clinically based dosing is the line in blue. And this was statistically significant. Another more recent trial is the Serene CD trial. Now, this was a double-blind, randomized controlled trial of higher versus standard adalimumab induction dosing, as well as 2 maintenance strategies. And so this included patients with moderately active Crohn's disease with demonstrated endoscopic activity. And patients were first randomized 3-2 to either a high-dose adalimumab induction regimen or a standard dose adalimumab induction regimen. I'm not going to get into the details of the induction regimen, but I will tell you that the high-dose induction regimen received about 3 times the total drug compared to the standard dose induction regimen. And then they were re-randomized at 12 weeks at the end of this induction period to 2 maintenance strategies. The conventional advancement strategy, which was escalation of dose based on clinical symptoms or CDAI or CRP only, or a TDM based advancement where they were targeting a concentration of greater than 5 micrograms per ml. There were a number of endpoints assessed, and importantly, in the maintenance assessment, these were all exploratory endpoints. I'm not going to get into the details of the data for the induction portion, but I will say that there was no difference in outcomes generally between the 2 induction regimens at 12 weeks. Here I'm sharing the results of the maintenance strategies at week 56, and you can see there are a number of outcomes assessed, both clinical and endoscopic, and there was no difference between the clinical advancement strategy and the TDM advancement strategy. One point I'd like to highlight, though, is how many were indeed escalated to 40 milligrams weekly from every other week on each of these strategies. And although it was higher in the TDM-based group, 39%, it was still a reasonably high rate of dose escalation in the clinical advanced strategy of 28%. The third and last example of a randomized controlled trial for proactive TDM I'd like to share is the PILOT trial. Now, this was an importantly non-blinded randomized controlled trial of proactive versus reactive TDM for adalimumab maintenance therapy in pediatric Crohn's disease. So this included pediatric patients with Crohn's disease who were biologic naive and who exhibited response to adalimumab induction therapy. So then if they exhibited response at 4 weeks, they were randomized to either adalimumab maintenance with proactive TDM, where they targeted a concentration greater than or equal to 5 micrograms per ml, or adalimumab maintenance using reactive TDM, where they were informed of the drug and antibody levels only in response to clinical symptoms and CRP or calprotectin elevations. They're followed quite a long time, until 72 weeks. And the primary outcome was a sustained remission outcome. It was sustained corticosteroid-free clinical remission between weeks 8 and 72. So how many patients were in corticosteroid-free clinical remission at all time points between weeks 8 and 72? And here they did find a statistically significant difference between the 2 maintenance strategies. So the percent of patients with sustained corticosteroid-free clinical remission was much higher, 82% in the proactive strategy compared to 48% in the reactive strategy. And then also they looked at a composite sustained corticosteroid-free clinical remission in addition to biochemical evidence of remission with CRP less than or equal to 0.5 milligrams per deciliter or fecal calprotectin less than or equal to 150 micrograms per ml. And indeed, the proactive group had superior outcomes for this composite endpoint compared to the reactive group. So these are 3 examples of randomized controlled trials for proactive therapeutic drug monitoring. And there have been a number of other studies, and I won't be able to get into the details of all of them here. But a group performed a meta-analysis of randomized controlled trials, and they identified 9 RCTs, mostly in adults, mostly in maintenance phase, that included over 1,400 patients. And they compared proactive TDM to conventional management. And using this meta-analysis of randomized controlled trials, the end result favored no benefit of proactive TDM over conventional management. And secondary outcomes showed a higher rate of dose escalation with proactive TDM, which is not surprising, and no difference in the rate of anti-drug antibodies. Now, another group took a different strategy to a meta-analysis and included both randomized controlled trials and observational data. And again, perhaps not surprisingly, they did find some benefit when including the observational data of proactive TDM compared to conventional management, particularly for treatment failure, as shown on the left, which favored proactive management. A lower rate of surgical intervention was nearly statistically significant in the proactive management in this meta-analysis. And although there was a tendency towards higher clinical remission, this was not statistically significant, favoring proactive. So why are we seeing these differences in the observational studies compared to the randomized controlled trials? And of course, randomized controlled trials are our gold standards, but there are some challenges of designing an RCT to study something like proactive TDM. And I'll give you some of my thoughts here. One is we're attempting to prove an incremental benefit of a management strategy for a drug that's already proven effective. And not every patient is going to require dose escalation that would lead to improved outcomes. So we're going to require a very large number to show this increase in effectiveness of an already proven effective drug. Another reason is that most of these randomized controlled trials follow patients for 40 to 52 weeks, and we may need longer follow-up to capture differences in anti-drug antibody development, relapse-free survival, and treatment failure. And we did observe that the Pilot study, which was longer in follow-up, resulted in a positive outcome. Another point is that equipoise may not be present such that we can study this in the most rigorous fashion. So for instance, the TAXIT trial included initial dose optimization for all, effectively giving all the patients proactive therapeutic drug monitoring, presumably because they thought this was standard of care. We're also noticing high rates of dose escalation in the control groups in these studies. And I wonder if monitoring an escalation of a conventional management arm in a clinical trial may not reflect general practice. That is, would biomarkers like CRP and calprotectin and would assessment of symptoms be reacted to as promptly and as frequently in clinical practice as it is in a structured, closely monitored clinical trial. And lastly, the use of a concomitant immunomodulator may be another effective strategy to prevent immunogenicity. And in some of these trials, patients were on immune modulators, and that may be an alternative and mask any benefit to proactive TDM. So with that evidence in mind, I will share some guidelines from medical associations and expert consensus and the practical approach to TDM that we employ in clinical practice. So to my knowledge, there is only one published guideline for therapeutic drug monitoring in inflammatory bowel disease by the American Gastroenterological Association. It was published in 2017, so it is getting a little long in the tooth. And with regard to anti-TNF drug monitoring, they made the following statements. In adults with active IBD treated with anti-TNF agents, the AGA suggests reactive therapeutic drug monitoring to guide treatment changes. And this was a conditional recommendation and based on low quality of evidence. With regard to proactive TDM, they state that in adult patients with quiescent IBD treated with anti-TNF agents, the AGA makes no recommendation regarding the use of routine proactive therapeutic drug monitoring. And they felt there was a knowledge gap in this area. So this is not terribly helpful for guiding us in using TDM, particularly in a proactive fashion. Another group got together and used a Delphi consensus method to produce an expert consensus statement. And on this slide, I am paraphrasing and summarizing some of the statements that I think are most helpful. So they felt that reactive TDM should be performed for confirmed primary non-response and secondary loss response to anti-TNF drugs, and that was the strongest evidence for anti-TNFs, but also for vedolizumab and ustekinumab. They proposed that after reactive TDM for secondary loss of response to an anti-TNF therapy, one should not discontinue treatment until you've pushed the drug concentration to at least 10 to 15 micrograms per ml. They propose that proactive TDM should be performed after induction and at least once during maintenance for patients on anti-TNF. And that proactive TDM is most important in more severely active patients and in patients who have higher drug clearance. They also state that more data are needed to support the use of proactive TDM for biologics other than anti-TNF therapy. So I think that these statements give us a little more guidance. I think there are some patient groups that may benefit most from proactive TDM, and of course the best evidence is in anti-TNF therapy. So one is pediatric patients. They continue to grow and develop physiologically, and we don't have as great data about their drug pharmacokinetics. I agree that patients with severe disease may benefit more from proactive TDM. And one marker of that may be a low albumin, less than 3 grams per deciliter, that may be reflective of the high protein leak in more severe patients. Patients with perianal fistulizing Crohn's disease, who we know that healing of fistulas is associated with higher thresholds of anti-TNF drug levels, and so they may benefit more. Patients on monotherapy may benefit more because they are not afforded that protection of the concomitant immune modulator, and this may be an alternative to concomitant immune modulator for preventing anti-drug antibodies. And then I also think if you have a patient on a second anti-TNF who had a history of anti-drug antibody development on the first anti-TNF, it's reasonable to monitor them more closely for the development of anti-drug antibodies. Here I'd like to propose some principles that I use in my practice for TDM. So proactively maintaining a minimal drug exposure will reduce risk of immunogenicity and therefore increase durability. Some patients will require a drug concentration higher than your initial minimum target to achieve clinical and/or endoscopic remission. You need to know your assay. The interpretation of anti-drug antibody results really depends on the assay used. For some assays, low anti-drug antibody concentrations may not be clinically meaningful. And intermediate anti-drug antibody concentrations can be reversed by the addition of immune modulator in some patients. And this may seem obvious, but the management depends on the results, and these results should inform how you manage the patient. And I'll go into that in more detail in the next slides. So these algorithms will represent our approach to TDM in pediatric patients with IBD. And this one is our approach to proactive anti-TNF TDM in inactive patients. And so some key assumptions here on the left are that these are clinically inactive or improving patients who initiated therapy, that the CRP or calprotectin levels are at target or improving, and that later on, at 6 to 12 months, we've seen endoscopic improvement, significant improvement, or even endoscopic healing. The target drug levels are in the chart on the top right. So if we're measuring infliksymab at week 8, prior to the third dose, we're targeting a level greater than or equal to 18 micrograms per ml, which correlates to a level greater than or equal to 5 in maintenance. If we're measuring infliksymab at week 14 before the fourth dose and in maintenance, a trough level, we're targeting greater than or equal to 5. For adalimumab at week 8 or in maintenance, we're targeting a trough level greater than or equal to 8 initially. And so when a patient starts this therapy, we check levels either in late or post-induction in every 6 to 12 months. And so when you get the results of your level, the level could be greater than or equal to the target. And if, as would usually happen, there's undetectable or low anti-drug antibody levels, then there would be no changes to the dose or interval. And we'd continue with this monitoring strategy. It's possible, but unlikely, you could detect anti-drug antibodies at an intermediate or high level in the setting of a target drug level. And it's sometimes hard to know what to do in this setting. It may be appropriate to monitor these patients and determine whether these appear to be indeed neutralizing antibodies, because if the drug level does not change in the setting of a higher antibody, these may be non-neutralizing antibodies, which are picked up by some assays. Or one could add an immune modulator in the attempt to reverse these anti-drug antibodies. Now, what if the drug level is below our target? Well, again, it's possible that it's a low level without anti-drug antibodies detected. And in this case, one needs to increase the dose or decrease the interval to achieve the target level, and needs to recheck the drug level to confirm we've achieved that target level. It's also possible that there would be a low drug level in the presence of high anti-drug antibodies. And if they're quite high, and if the patient initially responded to this first anti-TNF, then it would be reasonable to switch within class. The mechanism worked, but we've developed immunogenicity. And if we're going to switch within class, it is also reasonable to start an immune modulator to prevent anti-drug antibodies with the second anti-TNF. And now there's sometimes this realm of an intermediate anti-drug antibody level. And in this case, you may have the opportunity to reverse it if the patient is not on an immune modulator drug. And so if they're not on an immune modulator drug, of course, we're going to increase the dose or decrease the interval, but we could have the opportunity to add an immune modulator drug and potentially reverse the anti-drug antibodies. If they are on an immune modulator, one can try to reverse the antibodies simply by escalating the dose and improving the exposure, but it may be time to switch to another anti-TNF, again, assuming that there was response to the first anti-TNF. Now let's discuss our approach to reactive anti-TNF therapeutic drug monitoring. And this is in active patients. When I say active patients, it's not just in response to patients with symptoms, but also patients with worsening endoscopic activity or persistent endoscopic activity, or patients with biochemical evidence of disease exacerbation, high CRP, fecal calprotectin, where there's not another cause identified. And in this setting, particularly for symptoms, I will consider empirically giving an early dose or a higher dose while I'm simultaneously checking anti-TNF drug and anti-drug antibody levels. And because these levels take about a week to come back, and we want to take care of our patient. So in the setting of activity, we check drug and anti-drug antibody levels. One possibility is that the levels are quite high, greater than or equal to 15 for infliksymab or adalimumab. And in this case, we can assume a pharmacodynamic or mechanistic failure, meaning there seems to be adequate drug exposure. We don't expect that more drug would help. And the patient does not seem to be responding to this mechanism of action. And so, of course, we want to confirm again that there's indeed active inflammation causing symptoms. It's also an opportunity to assess whether surgery is indicated, whether medical therapy is likely to improve this patient. But assuming there's not an indication for surgery and there is active disease, at this point, one would switch to a drug with a different mechanism of action because the anti-TNF exposure is adequate and the mechanism is not working for this patient. On the other hand, infliksymab levels may be quite low, lower than our initial targets. And when there's no anti-drug antibody detected, this is a pharmacokinetic or PK failure, but it's non-immunogenic. The patient is simply clearing the drug more rapidly than other patients. And we would expect they would respond to an increased dose or decreased interval to improve drug exposure. On the other hand, a patient with low levels may have very high anti-drug antibody levels. And this is also a PK failure, but this is an immunogenic PK failure. It's due to anti-drug antibodies. And when they're quite high, we don't expect them to be able to reverse by an immune modulator. And if the patient previously demonstrated a response to the first anti-TNF drug, this would be an opportunity to switch to another drug within the same class. And for anti-TNFs, I would recommend using a concomitant immune modulator with the second drug to prevent the development of antibodies again. Now, once again, we could get an intermediate anti-drug antibody result. Again, this depends on your assay and knowing your assay. And if a patient's not on an immune modulator, this may be an opportunity to add an immune modulator as well as increase the dose or decrease the interval. But if the patient is already on an immune modulator, depending on the antibody level, it may not be effective to simply increase the dose or decrease the interval. And I would recommend switching to another anti-TNF drug, again, assuming response to the first. Now, we've discussed what to do with very high levels when we're reacting to disease activity and what to do with very low levels. But what about levels in the middle? Well, when they're in the middle, we're not quite convinced yet whether this is truly a pharmacodynamic or mechanistic failure or not. And we don't know that until we push the levels higher. And so if there's no anti-drug antibody detected, as would occur most of the time when levels are this high, then we need to increase our dose or decrease our interval, as well as increase our target to over 15 micrograms per ml for anti-TNF drugs to prove that this patient doesn't just need a higher exposure to achieve remission and healing. Of course, if there is intermediate or high anti-drug antibody levels, we're going to increase the dose or decrease the interval. We're still going to target higher levels, but we may need to add an immune modulator drug in an attempt to reverse the antibodies. So let's talk about a few future directions for TDM. One is innovations in how we measure drug and anti-drug antibody levels, and potentially making it easier for patients to do this at home. And so a number of groups have looked at measuring drug and anti-drug antibody levels using dried blood spots or capillary blood, which patients can obtain at home. And in these two studies, you see very tight correlation between the dried blood spot measurements and serum measurements on the left, and between capillary measurements and serum measurements on the right. And the group on the right, they also showed that patients felt very good about obtaining these capillary blood samples at home, and there was a lot of patient satisfaction associated with this. So this would be one opportunity to ease obtaining drug and antibody levels, particularly in this era of telehealth. Another hot topic in the realm of therapeutic drug monitoring and biologic drug management is pharmacokinetic or PK dashboard-driven dosing. And I've been privileged to be part of a group that's developed a PK dashboard that's embedded in the medical record for pediatrics. And this dashboard, one can input patient level information like weight, albumin, inflammatory markers, and it will read out projected trough levels based on any dosing regimen you like. And you can even select what trough levels you would like to target. And so this dashboard is about to be tested in a NIH-funded randomized controlled trial led by Phil Manar at Cincinnati Children's Hospital. We expect enrollment to start this year. Dashboard-based dosing has also been studied by the group in Amsterdam that compared dashboard-based dosing of infliksymab to conventional dosing and found superior outcomes in the dashboard-based dosing. So this may be an opportunity for us, even without level information, to predict optimal drug dosing and intervals for our patients to really maximize drug efficacy and durability. I'd like to leave you with some takeaway points. Treatment targets for IBD should include resolution of symptoms, suppression of intestinal inflammation, and endoscopic healing. And therefore, there's a need to optimize biologic drug effectiveness and durability. Reactive therapeutic drug monitoring should be performed in response to evidence of new disease activity to rationally inform management of most biologic drugs. And proactive therapeutic drug monitoring of anti-TNF biologics may improve outcomes and may be particularly beneficial in pediatrics and anti-TNF monotherapy and severe or fistulizing disease. So I'd like to thank you for your attention. I hope that the information provided today gives you more confidence as you use and interpret therapeutic drug monitoring to optimize the effectiveness and durability of biologic medications in your patients.
Thank you, Dr. Rosen, for your very informative presentation on therapeutic drug monitoring. It looks like we have several messages in the chat, and so I will read out the first one to you. What would help improve biologics durability the most?
Thank you, Susan. Sorry for a slight delay in jumping on with the camera and microphone. First of all, I want to take this opportunity to thank everyone for joining, and it's really thrilling. This is really exciting, and thank you for joining us. So I think we gave a couple of ways that you can improve biologic durability. I think the evidence supports One is the use of an immune modulator, particularly with an anti-TNF drug. The evidence for most of the comments I'm going to make are much less strong for other drugs, as we've had anti-TNF drugs for so long. But particularly for anti-TNF drugs, the use of a concomitant immune modulator. And immune modulators include predominantly methotrexate and azathioprine or mercaptopurine. The other option to improve durability is to use therapeutic drug monitoring, particularly in the case of anti-TNF drugs, to assure a minimal drug exposure. And by ensuring at minimal trough level, I think there's now sufficient evidence to support that is an alternative way to improve anti-TNF durability.
Wonderful. Thank you. The next question is trough level measured the day of the next dose, or if not, what is the time frame?
When we talk about a trough level, that's exactly right. It's measured directly prior to the next dose. So for infliksymab, and one of the most commonly used anti-TNF infused drugs, that's given typically the label dosing every 8 weeks. So in maintenance phase, 8 weeks later, generally, when the IV is placed for the infusion, you draw a trough level before the drug is given. For adalimumab or other injectable drugs, but there's at least stronger evidence for adalimumab, another anti-TNF. Adalimumab is given every 2 weeks, sometimes increased every week in a patient. It may be difficult for a patient to time blood draw directly with the lowest point. I didn't share evidence here, but there have been studies of how much adalimumab levels change between doses. And for an injectable given this frequently, it might not be surprising that the level actually doesn't change all that much, maybe a point between doses in maintenance phase for adalimumab. So it may be not quite as important to get a precise trough level in the setting of adalimumab therapy.
Thank you. Next question is, are immunomodulators used for research purposes only?
Yeah, I'm sorry I didn't take the opportunity to explain immune modulators further, but immune modulator drugs, like I said in the last question, include methotrexate, generally at a lower dose, certainly, than is used for, let's say, chemotherapy, and azathioprine. We've been using these drugs for decades to treat inflammatory bowel disease, but now they're often used in conjunction with particularly anti-TNF drugs. So no, they are absolutely used clinically.
Okay, thank you. And you've answered the next one, basically. What assay type would you recommend?
Well, I'll tell you, in practice, we, at least in the United States, we may not have a ton of control over the assay that's given, and it's going to be different in different healthcare settings. Sometimes patients are getting them at labs closer to their homes, and those labs have preferred vendors. So we don't always have control. But if I do have control, I would choose an assay that is drug tolerant, meaning that you can detect drug levels, detect antibody levels even in the presence of drug. So a drug tolerant assay. Most of the assays are these days. I think that would be the most important feature of an assay I select.
Okay, thank you. The next question, could you please list FDA cleared labs where we can send samples to measure anti-drug antibodies? Which labs?
Sure. I'll make the disclaimer. I'm not, in the US, labs can be CLIA certified, but not necessarily FDA approved. So I'm not going to make any certifications around the FDA approval status, but I can tell you labs that are commonly used in the United States for measuring drug and anti-drug antibody levels clinically. And this will not be an exhausted list, and it's not preferentially, I'm not conveying any preference for these laboratories, but laboratories including LabCorp, Quest, Prometheus laboratories, Mayo laboratories, ARUP. These are all labs that are commonly used in the United States.
Okay, thank you. The next question, how do you decide which biologic to use first?
Yeah, well, thank you for the question. We could give an entire hour-long talk on the positioning of biologic drugs in inflammatory bowel disease, but I'll try to answer this succinctly. It can be a little different for ulcerative colitis and for Crohn's disease. In ulcerative colitis, we're often starting not on biologic drugs. We're often starting mild to moderate ulcerative colitis with 5-ASA drugs like mesalamine, with or without the use of corticosteroids like prednisone. But in patients who are unable to maintain remission with ulcerative colitis on that treatment, in the most severe patients who are refractory to steroids, we will often use infliksymab. In those who are moderate disease, maybe that are more steroid responsive, we're often using vedolizumab, but there are other options, increasing number of options, particularly for UC, to choose from, and we're learning how to position those drugs. For Crohn's disease, when it's moderate to severe, we are typically starting with a biologic drug. And typically the first-line drugs for Crohn's disease are either anti-TNF drugs like infliksymab or adalimumab or others, or drugs that block IL-12 and IL-23 or IL-23 alone. And there's now a number of options, including ustekinumab and risankizumab.
Thank you very much. And the next question is, being an ulcerative colitis person for 35 years, I started to go to a support group, and we would talk in this group. It seemed a high percentage of people enjoy drinking pasteurized milk. Have you seen any correlation or heard of anything that this could be a precursor?
I'm not. I mean, I think this is an area of particular interest worldwide. What can we identify preclinical inflammatory bowel disease and understand, what are the environmental triggers for IBD? We know that it requires a genetic predisposition, but that's only a part of it, particularly for ulcerative colitis, which has a large environmental contribution. And so, what are those environmental factors? I'm not aware of data specifically around pasteurized milk, so I'm not going to be able to speak to that specifically. We certainly see that onset of disease is often preceded by an infection. I certainly have several patients with a story of they traveled and developed traveler's diarrhea that they simply could not bring back under control, or they have their first bout of C. difficile colitis, another infection. And although we're able to eliminate the bacteria, they still have chronic inflammation. And we think that represents a feature of inflammatory bowel disease initiation. They have a genetic predisposition. They have environmental factors that have influenced them, patients, over the course of their lives. And then there may be a triggering event that where they're unable to restore the balance of inflammation in their intestine after an infection, let's say. So again, an important question, but the risk factors and environmental contributions to IBD, that could also be the subject of a hours-long talk.
Thank you very much. That's the last question in the chat. We appreciate your taking the time and giving us this very informative presentation. Oh, another question just popped up. Do you use pharmacogenomics to determine which drugs are utilized?
Yeah, thank you. Thank you for that question. So pharmacogenomics refers to genetic factors that may influence how you metabolize or respond in other ways to drugs. And so that is an interesting question we didn't get to cover in detail. In the field of inflammatory bowel disease, we have a long history of using pharmacogenomics because for the immune modulator drug azathioprine, we do know that we know multiple genes that influence how patients metabolize that drug, particularly influence whether they metabolize it quite slowly and then might be at increased risk for toxicity. So, so we do measure or do genotyping prior to starting azathioprine or mercaptopurine to mitigate the risk of that drug. Now, what about for other drugs or biologic drugs, which is the topic of this conversation? So for anti-TNF drugs, that data from the PANT study I shared did show some very interesting findings that patients who have a certain HLA type have a higher risk of developing anti-drug antibodies. And so particularly if you are not using therapeutic drug monitoring, at least proactive therapeutic drug monitoring in your practice, that may be very reasonable to do to help determine, which patients would benefit most from the use of immune modulator drug with the anti-TNF drug to prevent antibodies. Now, interestingly, particularly in the pediatric space, because many centers do proactive drug monitoring, there have been a number of studies that, although they have smaller numbers, aren't in the setting of centers that use proactive drug monitoring, they're not able to recapitulate this association, which suggests that if we're doing proactive drug monitoring, it may be that the genetic risk is less if we're making sure there's minimal drug level at all times.
Again, thank you very much, Dr. Rosen, for this very informative and I'd say excellent webinar today. And thank you, attendees, for listening. And I hope you learned a great deal during this presentation. If you're interested in PACE credits, please visit the Euroimmune US Academy site. And thank you for joining us today and enjoy the rest of your day. Bye, everyone.